syphilis. Um, all right. So, again, this is one of my one of the things I'm super passionate about, and I'm very glad to be here today to talk to y'all about congenital syphilis. So just to start with, I have nothing to disclose. We're going to go ahead and start with the epidemiology of congenital syphilis. And I will tell you that all of these epidemiological slides are from the CDC. The CDC has great information about all the states with congenital syphilis and syphilis among women in childbearing ages. And you will see how they go hand in hand together. That being said, it goes from 2012 to 2021 or 2021. As we all know, epidemiological data kind of lags behind because it takes time to crunch the numbers and all those kind of things. They just recently came out with 2022 data that is essentially almost the same as 2021, or it's about the same. And so I just didn't change my slides from that, but just know that this is still an issue, and the numbers are essentially almost the same. So you can see on the United States map to the right that the state of South Carolina is in the highest rate for primary and secondary syphilis. And these are rates that are reported cases by state. So you can see that we are in a hotbed, and actually pretty much all of the South is in hotbed. So you know how we always say we're, last in something, but y'all, we're number one in STIs. So we got to get out there and really try to work on this. Next slide. You can see here in the state of South Carolina that there is a lot of hotbeds. Of course, the upstate here. So I was glad to see a lot of people in the upstate. Here's the PD. And then, of course, your other hot zones are in the Midlands and then at the Low Country as well. And so this is becoming more and more of an issue, especially in the urban areas, but also in the rural areas too. So I'm glad that we have a bunch of different practitioners who are on this phone call to hear this today. Next slide. You can see that congenital syphilis cases over the last 5 years or so have dramatically increased every year. So last in 2021, we're around 2,800 cases per year, which doesn't seem like that's a lot per se, but honestly, it is a lot because we can prevent congenital syphilis in pediatric patients. And that's where it's so great to have the OBGYN colleagues come in and help out with bridging this gap between OB and pediatrics to help try to decrease this number as much as possible. So you can see that this is the blue color here is the number of congenital syphilis cases per year, but this echoes exactly what is going on in as far as primary and secondary syphilis rates in females during childbearing years. And that's typically 15 to 44. So they go hand in hand. And so trying to identify these women of childbearing years to be treated with syphilis, to get their partners treated for syphilis, that is a big key as well. I think sometimes we can't either get the partners in or, they get missed in some way. And so then these, women get reinfected from their partners. Next slide. Just looking at the different races and ethnicity of individuals, this American Indian population has dramatically increased over the last couple of years. And then you can also see that we have the Black African American group in the middle, and then the Hispanic and Latino as well. So just kind of keep in mind, even though that syphilis touches all races and ethnicities, there are individuals who that seem to have higher numbers sometimes than others Either way, the numbers are very high, and we should not be looking at races or ethnicities to determine who we need to treat or who we need to test for syphilis for sure. Next slide. Okay, so this is the rates of congenital syphilis, and this is, of course, reported from 2021. We're somewhere right here at 33.2. So we're not the highest, but we're definitely surrounded by high numbers. Poor Mississippi over here is pretty high, so at least we're not number one, but we are on our way to getting to be close to being some of the highest numbers out there. New slide. Next slide. Yeah, thank you. Okay, so this is congenital syphilis reported cases by vital status and clinical signs and symptoms. Okay, so this is super important to know, but basically what this means is that what are the signs and symptoms of the actual individual infant, and how do they get diagnosed with syphilis? You see the majority of the patients here are alive with no documented signs or symptoms of congenital syphilis. That is huge. So for pediatricians, family medicine practitioners, etc., it makes it very difficult to identify patients who could have congenital syphilis with signs and symptoms alone on physical exam. And this is where testing really comes in to being both looking at the mom's testing and the baby's testing to compare the two to know where we are as far as what their risks are from getting congenital syphilis. Next slide. So here you can see that the maternal syphilis rate, the highest rate is in those individuals, those pregnant individuals who have no prenatal care. Now, obviously, this is a big push. I know DHEC is looking into this, how to get awareness, how to get these individuals in early for, prenatal care. How can we capture these individuals? But it also means that we will have pregnant individuals coming in to deliver babies that have zero prenatal care. And those are the ones that we really need to be interested in and looking at their syphilis status as well. You could see we have less in the third trimester versus second trimester versus first trimester here. But we still capture them in all these trimesters. So just really quickly, I'm going to go over syphilis testing. You probably know this like the back of your hands, but it really does get sometimes confusing. And knowing how testing on mom really affects what we do with this infant is super important to understanding how this testing goes and how we use it as pediatricians. So, of course, with laboratory diagnosis, you have to have both a non-treponemal test and a treponemal test. That you have to have both of them because, unfortunately, the non-treponemal test has a lot of false positives. I actually have caught sometimes, several times actually, where the mom comes in and gets an RPR but never gets the treponemal test to go with it. So sometimes I'm calling and saying, oh, I need to have that reflex. Most laboratories in major hospital settings will have some kind of way of reflexing the first test to the second test. Next slide. So we're going to start with a treponemal test. Treponemal test is great because it gives you a lot of true positives and less false positives. But there are some false positive tests that can occur, and most of the time these are with other spirochetes diseases. You can see the long list there. How often do we really see any of these things? We see rat bite fever in pediatrics, but I doubt that you see those in your population. Lyme disease, just FYI, is not in the state of South Carolina. It is in it can be in some of our ticks, but we don't have Lyme disease that is regional in the state of South Carolina. So if you look at the CDC website and you'll see South Carolina cases, those are all travel associated cases, by the way. We do have something that's similar to Lyme disease, but not Lyme disease in itself. Next slide. And then we have a non-treponemal serologic test, and this is the one that we know. RPR typically is the ones that we use most of the time, but there's also VDRL as well. The really good thing about this one is it's quantitative. So it gives us a number that we can look at where the mom and or the patient is in their syphilis diagnosis. You can see a lot of false positive testing, sorry, and you don't have to go back to the other, but you can see here, look, what is one of the biggest reasons for false positive testing? Pregnancy, and y'all know that. Next slide. So the CDC still likes for people to do traditional testing. And what does that mean? That means that you actually use the RPR or a VDRL to screen the patient, and then you confirm with a treponemal antibody. And that's the way that it has been for a long time. But now most institutions do what we call reverse sequence screening. So if you ever see that term, what that actually means is that you are using the treponemal antibody as your screening test, because that has a lot more or a lot less of false positives, and then you confirm it with the RPR. And that's important to know what your institution does where you send your testing. You know, I know if the patient already has a history of having syphilis, obviously the treponemal antibody will stay positive for life. And then you actually just use the RPR to figure out where they are, if they've been reinfected, et cetera, or if they're serofast. But that being said, you know, you kind of have to know your patient and where you are. But if the patient has never had syphilis testing ever, you have to do both. All right, next slide. Okay, so this is the one thing that I want y'all to get out of my presentation, okay? So the CDC states that serologic testing should be performed twice during the third trimester, okay? If you're in an area that has a high burden of syphilis in your population. Y'all, that is South Carolina. We count as that demographic, okay? So not only should you be doing syphilis testing in the first trimester or the first prenatal visit, but you also should be doing it in the third trimester, and you really need to be doing it at delivery, okay? And that is very important because, as you will see, not having those individual testing at the third trimester and time of delivery significantly changes or can change what we do for the infant. And we are constantly having to call OBGYNs to get that particular testing on the mom so we can know what to do with the baby. And we'll get into that in just a little bit. Next slide. So the other really neat thing here is that ACOG just came out with a practice advisory, okay, that said also that OB care professionals should screen all pregnant individuals serologically for syphilis in the first prenatal care visit, followed by universal screening during the third trimester and again at birth. So they echo the CDC, and actually they didn't even take into consideration where you live and whether or not the syphilis burden is high. They say this should be universal across the board in the United States. So we really need to work on trying to get these trying to get us to work together to get admission, order sets changed where, and, a treponema antibody or RPR is already pre-marked, that we're getting these on these pregnant individuals as soon as they come into the hospital, etc. Because that, again, just does make a difference. And so, again, CDC recommends, this, women with syphilis infection. There are certain maternal risk factors that increase your risk for syphilis: sex with multiple partners, sex in conjunction with drug use, late entry to prenatal care, no prenatal care, drug use, incarceration, unstable housing. So all of those behaviors, obviously, we need to look into in getting repeat syphilis testing. But just like I said, ACOG now has gone against that and saying everyone should get it. Okay. So what do we do about treating women or pregnant individuals with syphilis infection? The drug of choice is IM penicillin. Okay, we all know that right now benzathine penicillin is on a shortage, but most institutions, at least Prisma Health anyway, and I'm assuming MUSC and other hospitals in South Carolina are the same, that we are protecting the amount of benzathine penicillin that we have for those individuals who need it the most. And who falls into that category? Pregnant individuals and children. Okay, so you should be able to get benzathine penicillin. You should be at the top of the list for your patients to be able to get it. Okay, but the most important thing is to know what stage the mom is in, as far as knowing how to treat the individual. Okay, so primary syphilis, we know that is brand new syphilis. They get 1 dose of benzathine penicillin. Secondary syphilis gets 1 dose of benzathine penicillin. That's, if you have lesions on your hands, a rash, etc., and you have the actual lesion itself for syphilis. Okay, but latent syphilis, which is the majority of the patients that we pick up during their initial pregnancy evaluation, requires 3 doses of benzathine penicillin, and y'all know this, 1 week apart. If we don't get those individuals, the pregnant individuals, in to get all 3 of those doses, it changes what we have to do to the baby when the baby is born. Okay, so if that mom does not get all 3 doses, then that requires an LP on the baby and maybe 10 days of IV penicillin in the hospital. Okay, so just knowing, making an effort to get these individuals in to complete their therapy really does make a big difference on what we do for the baby. It's really important also to count if there's missed days in between these, the first dose, the second dose, and the third dose. The optimal time, like I said, is a week, and that's what we usually strive for. But if you have any missed doses greater than 9 days, you have to restart the therapy all over again. Okay, and that's also very important for us to know. The other really big thing here too is it's super helpful for the pediatrician, family medicine doctor, etc., to have exact dates of when the treatment happens so we can go back. Part of the reason why we need that date is so we can make sure that the last dose that mom gets is at least 4 weeks prior to delivery. If it's not 4 weeks prior to delivery, then again, that causes the baby to get a lumbar puncture and to get 10 days of IV penicillin in the hospital. Okay, so it really does make a difference. And if we can't find that information, then we have to opt to be most conservative and go ahead and do all of that information or all of that testing. Next slide. I just said that, so next slide. Okay, So most women will not have a fourfold decrease in titers before delivery. Okay. So I've had several practitioners call me and say, I think they failed therapy because they don't have a big enough decrease in the maternal titers. That is not anything that I really worry about. Mainly it is just to make sure that they receive the correct doses for their stage and that it is at least 4 weeks prior to delivery. Okay. So follow-up titers should not be repeated until at least 8 weeks after treatment is complete. And so a lot of times we don't have that. The caveat to that is unless the mom is going to deliver, so we still need it in the 3rd trimester and right before delivery. Okay. So penicillin allergy. We all know that one of the reasons why people should get desensitized to penicillin if they have an allergy is for syphilis during pregnancy. Okay. Any other treatment that you give the patient during pregnancy completely negates the therapy according to the way that the pediatrician looks at it. And the baby has to get a lumbar puncture and 10 days of IV penicillin. Okay. Because that is not an appropriate consideration of therapy for that baby. Okay. So it is really important to kind of know your penicillin allergies. Now, I will go off on a little tangent here and say the majority of people who are labeled with penicillin allergy are not penicillin allergic. Okay. So with antimicrobial stewardship, this is one of the directions that ASP is going into to try to get individuals delabeled from being penicillin allergic. Most individuals will lose the antibodies, even if they have an anaphylactic reaction to penicillin, they will lose those antibodies by 10 years after that event. Okay. And so if you truly have a patient that is pen allergic, then you have to get allergy and immunology involved to get that individual desynthesized. If not, they can at least help you delabel the patient. All right. So then you feel comfortable giving that patient the penicillin. Obviously, HIV infection, that placental inflammation that you can get from congenital syphilis might increase the risk for perinatal transmission of HIV. So those individuals who are co-infected, it's really important to get that syphilis under control. So we can try to help protect both the mom and the baby from getting, transmission of HIV. Okay. Next slide. So we've kind of all talked about that. So we're going to skip that as well. Next slide. So I'm going to kind of go into some what congenital syphilis looks like clinically. We never see individuals, thank goodness, like this picture right here, but that truly is what individuals could look like or did look like with congenital syphilis that was never treated. Obviously, this picture was most likely taken before penicillin was found as a drug where we didn't have good therapies for syphilis, but we never, ever want to get to this place ever again in medicine. And this is what our whole goal is, to try to get pregnant individuals treated early. Okay, so congenital syphilis lacks a primary stage and it is disseminated through the blood. Transmission can occur during any stage of syphilis, but the risk is much higher during primary and secondary syphilis. And then fetal infection can occur during any trimester of pregnancy. And we've shown that with the epidemiological data from previous slides. Next slide. So most individuals, most babies who are truly going to be congenital syphilis infected, okay, will present somewhere between 2 and 4 months of age, but they absolutely will present before 2 years of age. Okay. I've had probably about 4 times in my 16-year career where I have caught congenital syphilis in an infant during this time period in the first 2 years of their life. Okay. But most of the time we are able to not have the child end up developing congenital syphilis because we've done a pretty okay job at getting babies treated early on. Okay. At that time, 2/3 of infants with congenital syphilis are asymptomatic at birth, but by the year of 2, most will present with symptoms. And again, 3 months of age, I said 2 to 4, but it's somewhere around in there. Okay. So approximately 40 to 60% of symptomatic infants at birth have at least one of the following. Okay. Hepatosplenomegaly, nasal discharge, mucocutaneous lesions. Please don't touch any of those. I'm sure that you're not going to be touching the baby anyway, but a lot of times you might. So if the baby comes out and you're handing mom the baby, please, I know you're going to have on gloves, but the nasal discharge and the mucocutaneous lesions absolutely have spirochetes in it. And you can spread the disease of syphilis from mucocutaneous to mucocutaneous. So don't rub your eyes or anything like that. That has happened before in the hospital setting, trust me. They can have skeletal abnormalities, high drops, and then, of course, anemia and thrombocytopenia as well. So these are just nice little quick pictures. This is high drops. This is the snuffles, which is that nasal discharge. That initial picture of the person who had congenital syphilis, that's basically why he didn't have a nose, is because syphilis was never treated and there was spirochetes in the snuffles part. The hepatosplenomegaly, you absolutely, one of the biggest things that we will see on x-rays is periosteal thickening or periostitis. If a mom ever tells you that her baby has periostitis, you need to be checking that mom for syphilis ASAP. That is one of the first reasons why a child will have periostitis on an x-ray is congenital syphilis. Okay. Here's the rashes with the mucocutaneous lesions. And then they absolutely will peel their skin as well. So you have to be careful. That periostitis, by the way, is the reason why they get saber shins later on in life. Next slide. So what do we do for babies who we are concerned have a chance to have congenital syphilis? Next slide. What are the things that will help us bridge that gap to help communication between our OB colleagues and pediatric and family medicine colleagues to be able to give the baby the best care that we can? Knowing what the pediatrician needs to know is the mother's serological status for syphilis and history of prior treatment. That is huge. That is paramount. And needing to have dates of when mom was treated is also huge. Next slide. This right here, I know you can't read it and I don't want you to read it, and I'm not going through all of this, but y'all, this is what we have to go through every time a baby is born to a mom who has perinatal or syphilis during pregnancy. So the very first part of this algorithm all has to do with what mom's history is. And you can see that if mom was not treated at least 4 weeks prior to delivery, or I have undocumented therapy, or it was a non-penicillin drug, or there was maternal evidence of relapse or reinfection, or the partner was recently diagnosed with syphilis, that automatically gets you in the possible or proven highly probable category. And that has to do with your physical exam, essentially, right? In these two categories, at minimum, I have to do a lumbar puncture, and at minimum, typically you get treated for 10 days with IV penicillin in the hospital. And as we know, bonding of a mom with baby is very important, especially in the beginning. So having the baby have to be in the hospital for 10 days disrupts potential breastfeeding, that bonding period, etc. So it is something that, it's unfortunate it happens. We have to do it. We try to, work with the mom as much as possible to be able to visit the baby. But if we don't have to do it, that is the best case scenario. Next slide. And again, sorry, this is just FYI, y'all. This is from the last Red Book. There is a Red Book that just came out, yay, in 2024, by the way. That is the pediatric kind of Bible for infectious diseases. But these graphs and algorithms have not changed at all from the last Red Book to this Red Book. So I just left these slides in. So what is a full congenital syphilis workup? So obviously an examination, RPR, VDRL. You also have to get CSF. One of the test questions we always get asked, what is the non-treponemal test you check in CSF? It's the VDRL, not an RPR. We get long bone x-rays, a CBC, and then sometimes we have to get other tests, including MRIs, eye exams, hearing tests, all those kind of things as well. All right. And then, of course, we have the treatment options here. These change based upon what category the infant is put on as far as the risk of them developing congenital syphilis. And it ranges anywhere from nothing, that only occurs if mom has a history of syphilis prior to this pregnancy and stayed stable or serofast during the entire pregnancy. And then you have IM benzathine penicillin as sometimes an option, but most times, 9 times out of 10, we have to choose this 10 days of aqueous penicillin. So what are our conclusions here? The incidence of congenital syphilis is absolutely increasing, both in women of childbearing age or individuals of childbearing age, and also in babies. We need to be cognizant of it. We need to do our best that we can to get pregnant individuals in as soon as we can. I know that y'all try to do the best that you can in doing that, but that we also need to go ahead and institute in our practice screening for syphilis in the first trimester or first time you meet a pregnant individual, but also in the 3rd trimester and at time of delivery. That should be the #1 big take home that you get out of this talk today. Documentation is so important. I love to talk to all of my OB practitioners, and I will call you and hunt you down, but I don't want to have to call you because y'all are busy. You're delivering babies, you're doing all sorts of different stuff. So if we could find that documentation, that would be super helpful. I will tell you that one of the things that DHEC is looking into, and I really want it so badly, is a syphilis registry, because that will make it easy for practitioners to be, like myself, to be able to find the information that we need, and it might save some infants having to get, the full workup for congenital syphilis. If congenital syphilis is suspected in the baby, call us. We love to talk to you. Pediatric ID people, we're on call all the time. We get phone calls all the time. Don't think that that you're bothering us. Most pediatric ID people have a soft spot in their heart for congenital syphilis. So it's something that we like to talk about. And I appreciate your attendance today, your listening, and I would love to answer any questions that y'all might have for me.